Good afternoon, everyone. Welcome to our educational info webinar today on relapsed refractory multiple myeloma and what to expect. My name is Gabriele Closerdo. I'm the Manager of Education and Patient Services at Myeloma Canada. And before we get to the webinar, we'll just go over a few little things. So first, I'd like to thank our sponsors for providing educational grants to help us make these webinars possible. So thanks to Amgen, Binding Site, BMS, Janssen, and Takeda. We've been doing a lot more webinars these days. As a lot of you know, I see a lot of familiar faces on this particular webinar. And so our next webinar is going to be on Wednesday. So in 2 days from now at 2:30 p.m., we have Frank Courjal from the Binding Site, who will be presenting on how to follow and understand your serum free light chain test results. And so to register for that, same way you registered for this webinar, just go to our website, myeloma.ca, in the news and events section, and then choose info webinars and events, and you'll be able to register for that. All of our webinars are recorded. They're all, and we upload them all to our YouTube channel. So if you miss anything, don't worry. You can always come back to it and review some of the slides that you might have not understood or wanted to hear again. So if you go to youtube.com and you type Myeloma Canada in the search bar, one of the first links you'll see is Myeloma Canada. If you subscribe to the channel, every time that we upload a new video, you'll get a notification, and that's a good way to stay up to date with our latest webinars. From our website, you can also access our webinars. So if you click on resources, and then the window will open up, you click on educational videos. This will send you to our YouTube channel, and you'll see all the videos there. So before we get to the presentation, the last thing I'm going to talk to you about is how to ask questions. On your GoToWebinar software or the panel, you can click on the little sections tab. This box will open up, and then you type your question in here. You click send. I will receive the questions. Please send your questions as you think about them during the webinar. I'm going to compile them, and at the end of the webinar, I will ask our presenter all the questions, and we'll have a discussion about that. So without further ado, I'd like to introduce you to Dr. Arleigh McCurdy, who's a hematologist at the Ottawa Hospital and assistant professor at the University of Ottawa. Dr. McCurdy, thanks so much for joining us today.
You're welcome. Hi, everybody, and thank you for having me. Just a couple of things I wanted to say to start. I've been working from home today, and my 3 young assistants have been interloping a bit more than usual. So I'm hoping that we're uninterrupted for this hour, but it seems that they know when mom is busy doing other things. So hopefully this goes smoothly for us. So just getting started with respect to disclosures, I've done advisory boards for these companies that make our therapies in order to provide guidance for where these drugs go in the future in our Canadian market. So the topic to talk about today really is a broad one, and the topic I was given was relapsed and refractory myeloma and what to expect. And so I thought, thinking about that topic, what I'd really like to cover in the next sort of half an hour to 3/4 of an hour is just how we approach a patient who has relapsed myeloma, what the treatment options look like for patients in this population, some of the new things that are new and exciting, and where we're headed with respect to treating relapsed myeloma, and then have enough time for questions at the end, so that if anything isn't clear or there's something that I didn't touch on, that you would have a chance to ask those types of questions. And I think it's important for all of us, myself certainly included in this, to recognize that we're really a diverse group of people on this call. And so I suspect, without knowing for sure, that the age gap between the youngest and the most mature patient on this call or caregiver is 30 to 40 years. And there's probably people who are newly diagnosed and other people who are more veteran patients who have had multiple types of therapy. And we're all from different walks of life. And so just trying to remember that as we go through this, and hopefully everybody learns something in the hour, and there may be areas that you're more or less interested in depending on what you're looking for. And hopefully, if again there's things that come up, please ask them in the questions, and we'll get to that. So just to provide a little bit of context, again, this is a topic that is mostly familiar to you, but just with respect to what we're dealing with multiple myeloma, this really is a group of plasma cell disorders. And I'll get back to that in a second in terms of what a plasma cell disorder is. But this is the second most common type of blood cancer that we see. Lymphoma is the one that we see more often than that. But it's relatively common in Canada, despite many patients and family members and friends not hearing about it before having someone close to them affected. We see about 3,000 new cases per year, and there's somewhere between 8,000 and 10,000 patients living in Canada with myeloma right now. It's more common in men and more common in people of African descent, and usually an illness of people who are close to retirement age or in their 60s, although you know, I've seen patients in their 20s and patients close to 100, and so it really does affect a broad range of people. And survival really has changed greatly in the last decade, and we expect that to continue in the coming years as well, and we'll go over some of the reasons why. So any of my patients that are on the call, and I suspect there's a few of you out there, have heard this before, but I'm just going to reiterate it so people understand why we treat relapsed myeloma the way that we do. So most people know that it's a cancer of the bone marrow, and this is just a picture of a cross section of a femur, actually, and you can see the middle of the bone. In this part, it's sort of the spongy material called bone marrow, and that's really a factory. And so it makes different types of blood cells. So the red blood cells that make your hemoglobin, and so most of you are familiar with that, and that carries oxygen to the body and gives us energy. It makes the little blood cells called platelets that help us clot. And then it makes your white blood cells, which really are your infection fighters. And the plasma cells are a type of white blood cell made in the bone marrow. And their normal job is to make little proteins called antibodies. So what happens when these blood cells come in contact with a foreign invader of sorts, so a virus or bacteria, they get activated and they spit out these little proteins called antibodies, and those antibodies help with getting rid of the invader. What happens in multiple myeloma is that one of those switches in the myeloma cells that makes these proteins gets confused, and it basically gets stuck in the on position, and one of these cells starts to grow into this clone of myeloma cells. And so they grow in number, and when that happens, there's really two consequences. So one is they produce unregulated amounts of these antibodies or protein, and that's what we measure in the blood, either in the form of an M protein or abnormal band or a light chain. And the second thing they do is when these myeloma cells grow in number, they take up space in the bone marrow and they push those good cells out. And so that's why we have things like low hemoglobin when we're treating myeloma. And so our goal with treating myeloma, whether it's newly diagnosed or relapse, is to eliminate as many of these abnormal cells as possible so that the proteins don't cause damage to the rest of the body, and it allows the bones to heal. And so we want treatments that get rid of these guys and make this area more healthy. Again, a familiar topic, patients present in very varied ways. So common presentations that we see in the clinic are people who develop pain and fractures in the bones, as well as often a profound sense of fatigue. Sometimes the kidneys are affected, sometimes the blood calcium levels are high, and sometimes it's really just having recurrent infections over and over again that actually lead to the investigation and diagnosis. And this is just a picture of a lytic area. So one of these bone spots that we talk about, this is a patient's skull. You can see there, this is a bit of a hole in the bone that isn't there under normal circumstances. It's really important also to point out that this is what's called a heterogeneous disease. And so we know there's at least 7 types of subgroups of myeloma based on the genetics of those myeloma cells and the molecular features that we see. And it seems a very simple analogy to use apples, but these are all apples, but they're very, very clearly different. And they've evolved this way over time through different ways that they're bred, how the crops are cross pollinated and fertilized, and it's the same principle really in myeloma, as that there are different groups that look the same when we categorize it as myeloma, but they've really come to be through different genetic mechanisms. And so that's important to mention, that there are different groups of diseases that behave in different ways. In terms of what we call this, and I think this is important again for thinking about treatment, there's a concept of clonal tiding. And just walking through this cartoon with you, basically what happens is we have this tumor initiating cell. So something goes wrong in the signaling of those plasma cells, and they grow a little bit, but they have brothers and sisters as well. So there are these what are called ancestral clones. And these brothers and sisters tend to linger around in the bone marrow. And when we're diagnosed, we have this dominant clone in the middle, and it's spitting out the same type of protein. So for example, an IgG monoclonal protein. And then we do all sorts of things to this clone, and we treat it and we get rid of it and bring that M protein down to 0. But in the background, we still have these brother and sister clones that are joining and can cause problems down the road. And as the illness progresses, we end up having different groups of these ancestral clones that wax and wane according to different pressures in the bone marrow or chemotherapy. And so often when we're treating relapse disease, it's a little bit different than the disease that we started with in the first place. And this is an example. I really like this picture. It was published by Dr. Bergsegel from the Mayo Myeloma Group in Scottsdale back in 2012, but it sort of helps us highlight this issue. So we can see here in the middle, the color coding. These are different clones or different groups of myeloma cells that are all present in the bone marrow at diagnosis. And the predominant one in the bone marrow of diagnosis is this red clone. And then as the patient goes through treatment, we tested it again, and you can see that as they go deeper and deeper into remission, these smaller dominant clones go away. But then at the time of relapse, you can see that this original clone is not very big anymore, but we have this brother and sister clone coming in. And then there's a different chemotherapy that decreases the brother and sister clone, and then the other sibling comes in, and so on and so forth through each course of treatment. Sorry about that. And so at the end, when the illness has gone through 3 or 4 or 5 different treatments, we in fact see that it was just this little tiny blue clone that became the more serious one. And so these groups of cells wax and wane over time, and that's one of the things that makes this illness a bit challenging to treat once we've gone through a few different types of chemotherapy. We also have to remember that patients are very diverse. And so, this is not a group of myeloma patients. This is a picture that comes up if you Google diverse group of people, but it could well be my clinic. And again, patients have different levels of fitness. They have different perceptions about chemotherapy. They have different values and goals. And so when we're making decisions about treatment, we have to keep in mind the illness and those brother and sister clones, but also the patient. Like I was mentioning in the introduction, it's been a really exciting time for those of us who treat multiple myeloma in the last decade or so, and we expect that that's going to continue. It's really only been 10 years or so that we've had access to some of the quote unquote new treatments like Bortezomib or Velcade or Lenalidomide or Revlimid. And then more recently, just in the last 5 years or so, we've had approvals for Carfilzomib or Kyprolis, Pomalidomide or Pomalyst, Daratumumab or Dara, Ixazomib or Ninlero, and then recently Isatuximab was approved just very recently by Health Canada. And then we have many other agents here that are either being submitted to the FDA and Health Canada for approval or are in late stages of study. And so we expect that, you know, the 2020 to 2030 mark is going to be even much more crowded with respect to new medicines that are coming on board. This is just a snapshot of some of the different types of medicines that are coming, and I'll go into how these drugs work down the road. But I just wanted to put up that a slide to just show you that there are, you know, triple this amount of drugs that are currently being investigated at various stages. And so really a wealth of new treatments that are coming down the pipeline very soon. There are some basic principles, as I was mentioning, that we think about when it comes to actually starting treatment for relapsed myeloma. And one thing that I didn't really include in my slide, but really is, when do you treat relapsed myeloma? And so I'm going to talk about that a little bit and combine with these disease, patient, and access factors that we have. So when we're thinking about disease factors and when we would start a new treatment, we're going to take into account a few things. So one is the response to previous treatments. So there's a big difference in treating a patient who was in remission for 5 years after their first treatment, after, let's say, a Velcade-based treatment, versus a patient who was only in remission for 6 months after receiving a Lenalidomide-based treatment. And we're also going to consider any known high-risk disease. And high-risk disease we often think about with respect to something that's determined on special tests like FISH or cytogenetics or next-generation sequencing. But we also clinically can see a patient with high-risk disease based on other factors. So how well the illness does or does not respond, how quickly it relapses, and other clinical behaviors we see, like getting extramedullary disease, so tumor spots outside of the bone marrow. And when we initiate treatment is based on all of those things, in addition to how things change over time. So I often get asked, well, is there a magic number, or is there a certain point where you must consider treatment? The reality is that the definition of progressive disease requires a change in the monoclonal protein by at least 25% over 12 weeks or less, and that change needs to be at least 5 grams per liter, or if you're looking at light chains of change, of at least 100. And we sometimes see these things creep up over 9 or 10 years, and other times it happens over a couple of months. So not only do we look at the absolute number, but we look at the cadence or the rate of change. We need to think also about patient factors, and I was mentioning this a little bit. So fitness, frailty, and choice. And I think these are all unique from each other and equally important. And so we often think, well, you know, Mrs. Jones, for example, is a very fit 80-year-old, but we have to remember that a fit 80-year-old is still 80. And so some of the medicines are a bit harder to tolerate in patients who are more mature. Other times patients may choose a more aggressive treatment just because it suits their values a bit better. So all of these things are important. And frailty is an important one, and I have a slide on that as well. We're often, both physicians and patients, I think we underestimate how frail some of our patients and some of our family members may be. We also have to think about access factors. And so in Canada, much of what we can access, and I shouldn't say just in Canada, in most of the world, what we can access is based on what is available to us through funding mechanisms. In Canada, that's provincial funding. In other jurisdictions, sometimes that's national funding. But many of these drugs are on the order of $3,000 to $15,000 a month, and it's just frankly not realistic for most people to pay for these things out of pocket. We do have this illusion of a completely subsidized system in Canada, but the reality is that there are private insurance plans that pay for access to more drug or drug retreatment. And so it is something to think about when we're planning treatment going forward. This is just what I was mentioning about looking at frailty, and it's something that we often don't like to think about, but we do have to think about physiologic aging and vulnerability to toxicity. It's all well and good to be well enough to tolerate a treatment, but if it makes you too sick to continue, it really may not be worth it. And multiple studies have shown that if we take all comers with multiple myeloma, about half have some degree of kidney impairment, about a third have some degree of heart troubles, about a third have had quite serious falls, and importantly, about 30% are at high risk for depression, which obviously makes sense, but we need to think about these things when we're making treatment decisions, and we need to think about these things when we're following the treatments along. So just talking about switching gears a little bit into sort of what the current options are for treatment, I like to put up a cornucopia when I think about this. And, you know, you'll often hear us complaining in the clinic about restrictions we have of funding, but certainly compared to about a decade ago when I started in this field, our options for treatment have expanded greatly and continue to expand. And relatively speaking, we've actually done quite well with thanks from Myeloma Canada and other patient advocates like yourselves at moving these drugs forward into the landscape. And so actually, I think compared to many of our peers in the world, we actually have quite a good set of options and new drugs to choose from. And I think that's an exciting thing for us. The general principles when we're talking about treatments is that we prefer triplets over doublets. And what that means is 3 drugs instead of 2. And 3 drugs typically mean 2 chemotherapy or immunotherapy type drugs plus a steroid, such as dexamethasone or prednisone. And a doublet would simply mean 1 chemo or immunotherapy plus a steroid. And I have a little asterisk there because, again, this can vary depending on patient fitness and preference. Some patients may not choose to drive all the way into the cancer center to have injection treatment, for example. We often switch classes when we have relapse treatment. So if you started on a proteasome inhibitor like Velcade or Bortezomib, often we'll switch to an immune modulating drug like Lenalidomide or Revlimid, or vice versa. And one of the differences is that the vast majority of treatment in the relapse setting continue indefinitely until progression, meaning that, you know, with the exception of time out for travel, these drugs continue without interruption until such time that they don't work anymore, or if there are side effects that are not tolerable to the patient or a risk for safety. And just put a little plug in here that my bias is we should be considering clinical trials or research studies at every opportunity along treatment. A well-designed research trial may well be the best treatment option. And investigators like myself and colleagues really will only bring trials if we strongly think that they offer a chance at better treatment. So just something to think about if the opportunity is there when you're treating relapse disease. So let's talk a little bit about first relapse. And so the lingo can sometimes get a little bit tricky, but first relapse is called second line, meaning the second group of therapies that we'll have. And most Canadian patients are going to have second line therapy in either one of 2 scenarios. So patients who tend to be younger or a bit more fit physiologically will have had chemotherapy. Usually that's going to be Cyborg or involve Velcade-based treatment, followed by a stem cell transplant. And then most patients now would be treated with lenalidomide or Revlimid maintenance. Some patients will historically have not been treated with maintenance or have chosen not to have maintenance. And in some higher risk scenarios, they may be treated with things like Bortezomib or Bortezomib. But the typical first relapse patient will have had Cyborg, a transplant, and lenalidomide maintenance. The second option in Canada would be patients who were perhaps more mature or not well enough to have a transplant and had initial chemotherapy with one of the options I've listed there. So either lenalidomide or Revlimid is the other name for it, in combination with dexamethasone or Velcade and dexamethasone, and that typically is indefinite, or Cybordi or MPV, which is typically 9 to 12 cycles. Most second-line therapy in Canada will be given with daratumumab or Darzalex. And it's sort of the hot new drug in town, the one that everybody is asking about. And I certainly don't expect anyone to memorize these slides, but basically I just wanted to illustrate how this drug works and why it's different. So daratumumab actually is an antibody, same principle to these little proteins that are actually spit out by the myeloma cells. It's this little green molecule here that you can see. And it works in a few different ways. So basically it has these sticky little paws on it that go and attach themselves to CD38, which is a protein on all the myeloma cells. It's expressed on most myeloma cells, which is why it works so well. So its main direct effect is that there's a cross-linking phenomenon that happens. So these green antibodies stick onto the myeloma cell, cross-linking occurs, and the myeloma cell is killed. The other way it works is basically acting as a flag. So on the other end of these sticky bits that stick to the myeloma cell, you have a flag that flags down the immune system and attracts these different types of white blood cells to come in and help kill myeloma cells. So it really has multiple different ways of exerting its effect. And it's basically been shown to make all of the treatments, which are our old baseline treatments, it basically is shown to make them better when you use it in addition. So if you've not been on lenalidomide before, so lenalidomide or Revlimid, I use that interchangeably, the standard or go-to treatment would be the combination of lenalidomide, daratumumab, and dexamethasone. And that really was based on the Pollux study. And again, this is not put up here for memorization purposes, but this research study took patients who had had one previous treatment or more, and it randomized patients, meaning the group was divided into two, and half of the patients had the two-drug combination, and half of the patients had the same two-drug combination plus daratumumab. And what it showed is that the patients who had this three-drug combination, so the addition of daratumumab, ended up having a longer remission. So when this slide was made, it was not reached, but in fact, we now know that this group of 3 drugs tends to lead to remissions that are about 44 months long. So 3 years and 8 months, as opposed to this group of patients where typically we're seeing 20 to 24 months in terms of remission. So the addition of daratumumab makes this a better combination. It is reimbursed in all jurisdictions in Canada, and so this would be our standard go-to for patients who have not had lenalidomide. Many of you may have been in the circumstance about a year ago when daratumumab came to market, and some of the provinces allowed it to be added to patients who were already on this regimen. We don't yet know if that confers the same benefit. We hope that it does, but research studies are ongoing there. The next natural partner, again, at first relapse, is basically the opposite. So instead of using the lenalidomide with Dara and Dex, we would add Bortezomib, Dara and Dex. And basically this is a very similar study, but what was done is we took patients who had 1 or more prior lines of treatment, and then the groups were compared either the traditional backbone of Velcade and dexamethasone or the same with adding the daratumumab, and these patients were followed. And what we saw again is that the 3-drug combination ended up about doubling how long the remission was with the 2-drug combination. Importantly, the remission duration was not as long in this group as it was with the lenalidomide group that I mentioned on the last slide. So these patients, it's only about 17 months that the remission lasts, but most of these patients would have had a longer first remission because they would have had lenalidomide earlier. So if you have lenalidomide as part of the first line therapy, this would be an excellent choice for your second line treatment. I also wanted to mention Carfilzomib, as there may be patients who are treated on this, and it's also a good option for patients who have relapsed myeloma. Currently, we are not able to give this drug in combination with daratumumab, like the aforementioned two medicines. It has been studied in a study called the CANDOR trial, so that combination of Carfilzomib with daratumumab and dexamethasone. That's approved by Health Canada, but not yet reimbursed by the provinces. But it does look promising, and it may well replace Bortezomib and dexamethasone and Dara down the road. The reason it may replace it is that Carfilzomib, also called Kyprolis, is a stronger version of Velcade or Bortezomib. And we know this based on the Endeavor study, and that basically compared those two things head to head, where you had Carfilzomib versus dexamethasone, and the Carfilzomib works for about twice as long. So again, closer to that 18 to 20 month mark. I'm going to skip now to second relapse. So most patients in Canada, those three things I mentioned would have been your first relapse treatments or second line therapy. I do want to mention, however, that some patients can be treated with pomalidomide earlier, so in the second line or first relapse. And that depends a little bit on the province. So in Ontario, for example, to access pomalidomide, that I'll talk a bit more about, you have to have failed both a proteasome inhibitor, so either Bortezomib or Carfilzomib, meaning it has to have stopped working, and lenalidomide to have access to pomalidomide. Whereas in other parts of Canada, like Alberta, you have to be exposed to those other two drugs, but not necessarily refractory. And so there are some patients that may receive pomalidomide in first relapse, and that's okay. It's an excellent drug in that setting, but parts of the country we cannot use it until third line, and so it's been mostly used as a third line drug at this juncture. So second relapse or third line, most patients are going to be treated with a pomalidomide-based triplet. And pomalidomide is the newer member of the thalidomide-lenalidomide family. And so thalidomide, many of you may know, was really studied in the 90s for myeloma, and of course was famous in the 50s for all of the wrong reasons. But the family member of a myeloma patient who is a scientist realized that it may well be effective for myeloma and found that it was, but it had some nasty side effects with neuropathy and others. And so lenalidomide or Revlimid was designed to be more powerful and have less side effects, and indeed it was both of those things. And then pomalidomide, which is the third generation in that family, was designed to again be more powerful and have less side effects, and it is both of those things. And so right now, while we're trying to move this drug earlier in the treatments, it's typically used in the relapse setting. And most, there's been a plethora of studies looking at pomalidomide in combination with different triplets. And most of them have shown similar results, which I will go through. I think important to mention that very recently, the combination of pomalidomide with isatuximab was approved by Health Canada. Isatuximab is in the same family as daratumumab. It's an anti-CD38 antibody. And this is important because we can't access daratumumab to use with pomalidomide, so this may be a good option. It isn't funded by the provinces yet, but again, that private insurance question is an important one. So when we think about pomalidomide-based triplets, the most common one that we're going to see in Canada is the combination of pomalidomide with cyclophosphamide or Cytoxan and dexamethasone. And the cyclophosphamide, you know, is a very convenient medicine because it's taken once a week. The pomalidomide and dexamethasone are both pills as well. And so this is an all oral regimen that you take at home, less visits to hospital, and really from what we've seen so far, essentially as effective as the IV medicines in this setting. The best data for this combination is from a relatively old paper now, even though that's only 6 years, called the BAS study, where they randomized patients again to the 2 versus 3 drug combination. And what we saw is that adding that third drug, cyclophosphamide, increased the responses from about 5 months to about 10 months in this setting. And so this has really become a standard in Canada in this setting. More recently, we have seen the Optimism study, which combines pomalidomide with Velcade, or Bortezomib, and dexamethasone. And the results are a little bit better, and so we see closer to a year as opposed to 10 months. The downside being that this is an injection medication and involves weekly trips into hospital. And so thinking again about patient factors, willingness to travel back and forth, we have to consider whether or not that extra month or 2 of remission is worth the travel and cost associated with that. But certainly a very good treatment option, and one that is used quite commonly in Canada. I do quickly want to just touch on this most recent combination, which is pomalidomide, isatuximab, and dexamethasone. This took, again, patients who had had previous treatments and randomized groups to either having 2 or 3 drugs. And you can see here in the blue line that the people who had the 3 drug combination tended to about double the average remission of the 2 drug combination. And so the company Sanofi, who makes this medicine, is working to get this available to Canadian patients. But right now, the only way to access it likely would be through private insurance purposes, or mechanisms, I should say. We do, unfortunately, in most patients, will have another relapse. So then we get to our 3rd relapse, which is turned 4th line and beyond. And there isn't truly a standard care in Canada or even worldwide in this setting. And part of that is just because there is such varied access issues, and really the data that we have to support what the best care is in this setting is still in the process of being collected, evaluated, and the clinical trials are in fact still ongoing. And so what decision we make in Canada will depend on our access locally, private insurance, compassionate access programs, which some of the companies will have. And again, we strongly consider clinical trials if possible, because this is how many of the exciting new drugs are introduced into our space. I just wanted to take this opportunity to present a couple of slides about some of the new medicines that I mentioned earlier in the talk that are now being studied in the clinic, in clinical trials in these relapse patients, and are actually also being studied in patients who are newly diagnosed and in first relapse as well. So some of the new medicines that you'll become familiar with. So the first concept are these medicines that are called antibody drug conjugates. And you're probably getting familiar with this antibody medicine so far, but it's again this immune therapy where we're able to design these medicines. This here is the medicine with these little sticky paws that can go and attach to a protein on the tumor cell. So you'll remember that daratumumab that I talked about before is a type of antibody. The new part of these medicines that are being studied right now is the drug conjugate part. So that's where not only does the drug include the ability to identify the tumor cell, but it's conjugated and so attached to a chemotherapy medication. And so basically this drug functions like a warhead with a payload attached to it. And so rather than just attaching the cell and flagging down the immune system, it continues to do those things, but in fact, it inserts this payload or toxic medication directly into the tumor cell to kill it. And so it takes the concept of an antibody drug and then elevates it by including a conjugate. And so the one that you'll hear that's farthest along in this is called belantamab, which has also previously been called GSK 916. Many of us are using it in clinical trials now, and it will be coming to market, I suspect, sometime in the next couple of years, just because its efficacy is so good. But it's just one of about 10 different medicines that are being developed with this sophisticated sort of warhead and payload technology. And I apologize for the analogies, but it really is the best analogy to describe this type of medication. So the antibody drug conjugates are coming fast and furious and a very effective medicine to look out for. The second type of new kid on the block are bispecific T-cell engagers, and these are also called BiTE antibodies. The reality is that BiTE is actually patented by Amgen, so the company that first made one of these bispecific T-cell engagers. So we don't really term them all BiTEs anymore. We have to call them bispecifics. And these are, again, using that antibody immune therapy complex in a different way. So how these drugs work, obviously bispecific meaning two, we use two antibodies tail to tail with a linker in between them. And how the drug works is, again, you have these sticky paws that attach to the tumor cell, and your other antibody has sticky tails attached to T cells, which are really an important part of our immune system for killing tumors. And so when we give these medications where you have these antibodies linked, in fact, the linked antibody drug brings the tumor cell directly to its grim reaper, for lack of a better word. And so it's a way of harnessing the power of your own immune system and bringing it into direct contact with that tumor cell. And these drugs also maintain some of the direct killing that we see from the other antibody drugs to the tumor cell itself, or the myeloma cell, with that added benefit of pulling in the immune system. So most of these drugs don't have names yet. They're still in complex words like AMG 420, AMG 701, etc. But they are being studied in clinical trials right now, and we expect them to be in the market in the next couple of years. I should mention, importantly, with the drug antibody conjugates and these medicines, we are seeing effectiveness in patients who have really had myeloma for many years, or have gone through many treatments, 5, 6, 7, 8 treatments. And so these drugs offer a lot of promise, both in relapse patients and also likely will be more effective when they're moved earlier in the disease course, and those studies are ongoing. Lastly, I just wanted to mention CAR T cells, and CAR T cells are really in the media for good and bad reasons in the last couple of years. We've seen in other blood disorders like leukemia and lymphoma, we've seen some cures with this CAR T therapy. We have not seen cures yet with myeloma, but we have seen disease control. We have seen good activity in patients, again, who have very refractory myeloma. And we think that by using this type of technology with some of the other new medicines, we likely will get to a curative platform. And so I just want to explain what CAR T cells are and how they work. There are dozens and dozens of these different therapies being tested all over the world in myeloma, but they all carry really the same principle. So how CAR T cells work is that we actually harvest T cells from the patient, much like in a stem cell collection. We then make the fancy CAR cells in the lab. So these go from T cells to being CAR T cells. And the way that's done is that we manufacture a gene for a CAR, which is a chimeric antigen receptor. And using a virus, we actually, it's an attenuated dead virus, so don't worry, it doesn't infect anything. But we use that virus to get the DNA for the CAR into the patient's own T cells. And what the CAR T cell looks like is the patient's T cell, but with these little CARs on the outside. And these CARs are designed to, again, these little sticky bits you see here are designed to attack the myeloma cells. And so once we've infected the T cells with these CARs, we grow them, millions of them in the lab. They then go back into the patient, much like in a stem cell transplant. And then these CAR cells, so these engineered cells that are engineered to attack the myeloma, go and do their job. And so that's really the process for how we make any type of CAR T cell. And as I said, there are dozens and dozens of them being tested. And we often think about this with respect to younger patients because of the similarity to a transplant. But in fact, in many parts of the world, this is being done in patients in their 70s as well. And so it may well be an option for a wide range of patients when it does come to market. Currently in Canada, we are doing CAR T cells in the clinical trial setting. There is no commercially available CAR T for myeloma in North America. The farthest advanced is one called ida-cel, also known as BB2121, which is made by Celgene slash, I guess, BMS now, which BMS bought Celgene for those who didn't know. They were actually rejected by the FDA for some technical reasons, but we do anticipate that approval sometime in the next 6 months. And so we expect that we will see this commercially available in Canada sometime soon. Quickly, before we had time for questions, I just wanted to touch about some other important considerations in relapsed myeloma. We do need to be thinking about bone health. So it may be appropriate to be on a bisphosphonate medicine like Zomida or Pamidronate. Again, that needs to be individualized, so something to talk to your myeloma doc about. Most patients should be on calcium and vitamin D. Again, something to talk to your practitioner about. There is reasons we may want to avoid calcium, obviously, so an individual decision. Kyphoplasty or vertebroplasty for folks who are having difficulty with uncontrolled back pain. Sometimes we can do a procedure injecting bone cement. That may be something to talk to your doctor about. Infection prophylaxis is important. So most patients should be on acyclovir to prevent shingles. Depending on which treatment you're on, there may well be a role for antibiotics to prevent infections. Again, something to talk to your doctor about. Pain control is really important if you're having pain. Many of you out there are very stoic and most people don't like to be on medication. But the challenge we have is that the more pain we're in, the less we move, and the less we move, the weaker our bones and muscles get. And there's a bit of a cycle there. And so there may be a role for more aggressive pain control to get moving again and to allow recovery, and then weaning off the pain medicines when appropriate, because it is a bit of a vicious cycle otherwise. We do need, when we're taking lenalidomide or pomalidomide or thalidomide, any of those IMiD family members, we do need to be on medicine, either aspirin or a blood thinner to prevent blood clots, something to talk to your doctor about. And then last, but most certainly not least, is psychosocial care. And I hate to leave that to a last bullet point, but this is difficult sometimes dealing with relapsed myeloma. Despite all of the exciting news, it also can be challenging to live in pain, to be under stress, to be stressed about caring for a loved one, to have troubles with finances or being on disability. And so most cancer centers will have access to social work and psychology and can help with those types of things. And so important that if your team doesn't bring it up with you and you're struggling, please raise it with your team. So with that, I'm going to stop yammering, and I am more than happy to take any questions.
Thanks so much, Dr. McCurdy, for that overview. So we got a few questions here. We'll start with the first one here. This one's a yeah. So what does functionally cured mean?
That's a good question. Um, so, so it depends on who you're talking to. And so when we talk about a functional cure, what we're talking about is patients who we are using sensitive methods, we're able to detect that there are still myeloma cells in the body and particularly in the bone marrow, but that they're not causing any problems to the patient. And so functionally, the patient is actually quite normal, living a normal life with a normal life expectancy. Um, and a functional cure, really, many people think of as the goal, because really it doesn't matter if there's a few myeloma cells if they're not causing any problems. So that's what we would like to achieve. The difference between a functional cure and a cure is that a cure means that we would not be able to detect any myeloma cells at all. Conceptually, it'd be nice to have some of the, well, I guess it's never nice to have a tumor. I don't mean that at all. But it's easy to think about cure when you can cut out a lump, and without it having spread, it doesn't come back. That's a cure. And if we're able to eradicate all the myeloma cells in the same way, that's a cure. Functional cure is, yes, there's still some lingering, but they're not causing any problems.
And then, of course, there's also the school of thought where, does a cure mean being on therapy, or does a cure mean not being on any therapy at all for a long period of time?
Yeah, and so that's an excellent point as well. My own bias here is that a functional cure or a cure means not being on therapy. And I think it will depend down the road on what that looks like. So if being on therapy means taking, a daily tablet with no side effects, and a normal quality of life, then that's great. But I don't think our work is done until that's achieved.
Thank you. And so with that, I mean, we got a sub question with regards to cure here. And so does it ever happen that someone gets a first line treatment and they don't need any more treatment, or that they're functionally cured or cured?
Yeah, so a good question. So yes, I personally don't believe that those patients are cured. I think they're functionally cured. It's very rare, but it is important, and it is important to mention that everybody's a little bit different. So um, there are a subset of patients who have very prolonged remissions, and some patients who never require second therapy. It's about 1% of people in actual practice. So, for example, in my own practice, I have a patient who is transplanted in 97, still has a measurable M protein, so was not cured, but has never required more treatment. I have a couple of others who were transplanted in sort of the mid 2000s, and have never relapsed, and never required any additional therapy. And other patients who have required additional therapy instantly after a transplant. So it is varied. There is a subgroup of patients who have prolonged disease control, and that is much more likely the disease than the treatment. And that may sound obvious, but our own immune systems play a huge role in myeloma disease control, and you can kind of see that with how things are heading with all of these T cell therapies. But there are patients who have really good immune systems, for lack of a better description, and their T cells learn and are able to keep the disease in check. And those are the patients who have long-term disease control.
Awesome, thank you. So the next question, this is more of a general question with regards to someone's, I guess wasn't lytic lesions. Can you maybe explain a little bit, lytic lesions, they're holes in the bones, and there seems to be some confusion with, this person's asking, they thought that perhaps lytic lesions were bumps on the skin. So maybe if you could explain a little bit about plasmacytomas and lytic lesions and something?
No problem. So, yeah, so those are two separate things. So, bumps in the skin, if it's related to myeloma, would be what are called plasmacytomas. And those are little collections of plasma cells, so myeloma cells that occur outside of the bone marrow. And they're not that common early in the diagnosis, but certainly happen with relapse disease and really can happen under the skin anywhere on the body, although again, it's not that common. A lytic lesion is actually destruction of what's called the cortical bone, so that the outside layer of the bone that makes it increased risk for fractures. And so that destruction is caused by plasma cells or myeloma cells. And so sometimes this can be confusing because on the skull, for example, you can have plasmacytomas that cause lytic destruction of the bone and feel like a bump under the skin. So that's where it can be a little bit confusing. But for all intents and purposes, a lytic lesion is where you have destruction of the cortical part or the hard part of the bone caused by the underlying illness.
Yeah, so a lot of the times we'll see a picture of the skull with the little holes or the punch outs in them, and so lytic lesions can happen anywhere, not just on the skull.
Correct. Yeah, they can happen anywhere. Usually it's in the skull or what's called the axial skeleton. So the big weight-bearing joints like the femurs, hips, pelvis, back, shoulders. It's unusual for myeloma to affect anything below the elbows or below the knees. Although certainly in later stages or later relapses, that is a little bit more common.
Thank you. So, a lot of when someone is perhaps experiencing a relapse or maybe going towards a relapse, monitoring of M protein is something that is done. And, for example, if someone has, trace M protein, so really not that detectable, but, there's a small rise in the protein, it'll go, let's say, to 6 or something. Does that mean that necessarily that treatment should be started or that change in treatment should happen?
Good question. No, it doesn't necessarily mean that treatments should start. Like I was mentioning a little bit earlier, it really is, yes, the absolute number to a degree, but also the change over time. And so, definition wise, it's an increase of 25%, with the absolute change being at least 5 grams in an M protein happening over the course of 12 weeks. But really, you kind of need to take the long range in a respect with this, because sometimes patients will go from, say, 2 to 5 or 6 grams and then stay there for 5 years. And so you really have to look at how things are changing over time, rather than making the decision on 1 or 2 readings. And if you have somebody, let's say, who has very high risk disease where you're seeing that protein go 0, 5, 10 over the course of 8 weeks, that person needs treatment. Whereas if you see the person who goes 2, 4, 6 over the course of 6 months, you have time to wait there and maximize the treatment that you may already be on, or maximize the treatment-free period.
And for example, that person who goes 2, 4, 6 and maybe goes back down to 4, would changing the treatment perhaps have a negative effect versus a beneficial effect?
Yeah, so absolutely. And so that's where a little bit of the art comes into this. But one of the things that's important from a practical perspective is that once you change treatment, you can't go back to the old treatment. It won't be funded, so that's one issue. And you want to get as much bang for your buck. I mean, you don't want to, the reality is you don't want to throw the baby out for the bathwater. You're going to see fluctuations in M proteins. If you took an M protein measurement every day, so daily for 7 days, you would have fluctuations, because these assays are not perfect. They're read by eye by a biochemist. And so there's going to be up and downs. And these M proteins are known to bounce around from month to month. And so I just wouldn't want to change a treatment prematurely, shorten the potential benefit of that previous treatment, and then expose the patient to the risks of a new treatment, especially if they were tolerating the current treatment very well.
Awesome. Thanks for explaining. Now, the next question here, I know you practice in Ontario, but the question is Dara available in every province? I know you might not be able to answer that question, but from what you know, is it available in every province?
Yeah, I believe so. I think the subtleties between the provinces are really in exactly what circumstances you can use it. So it's absolutely approved by Health Canada. And I believe all of the provinces signed on to the negotiation. So long and short of it, just context-wise, there's a group called CAPCA that negotiates pricing with the companies once the drug is approved by Health Canada. And if the provinces sign on to that negotiation, they have 2 years from the time that the agreement is finalized to implement access to the drug. So there may be some provinces in like certain indications that are lagging behind, but as far as I know, it's available in every province.
Okay, thank you. Since we're talking about Dara, maybe we have a question here about, why is something like Dara not used in the maintenance setting? So maybe we can talk about that and a bit more about how drug approvals happen in Canada.
Yeah. So great question. So obviously Dara is an appealing medication to use in a maintenance setting and an appealing medication to use upfront in newly diagnosed patients. The data is further ahead with respect to newly diagnosed patients. And so I suspect that we'll see, at least in the transplant ineligible patients, a move to Dara frontline based on the results of a study called the Maya study that showed really promising effects in combination with lenalidomide. So we are pushing for that drug to be available to us. And so I think you'll see it in frontline before you see it with maintenance. With respect to maintenance, there is not good data available yet in a randomized way of Dara maintenance compared to the current standard. So in fact, I was on a conference call this morning planning our upcoming research studies, and we are going to be looking at it in a randomized trial coming up compared to standard of care. We have to remember that right now, in patients who progress on daratumumab, they don't do very well on the treatments that come after daratumumab. And so one of the challenging things is sorting out, if you give Dara for maintenance and you can't use it as relapse, does that actually harm your chances for success down the road? We don't know the answer to that. And one of the challenges is that we're trying to look at the end of the day, what changes survival, what is going to make patients live 20 years instead of 10. But we're having to wait very long times to get those outcomes. And so we don't know with certainty yet whether the sequence of Dara is as important. And so it's under investigation. But I think, that's a long-winded way of saying you will see Dara up front. The studies have been done and are ongoing, and we're moving towards that. It's not really done anywhere in the world right now. And you will see it in maintenance, but where exactly it fits in the next 5 or 10 years, we don't know.
Okay, thank you. I know that you, during the presentation, you had mentioned that in certain provinces, pomalidomide might be able to be accessed as a second line versus third line. Are there any benefits to that? The school of thought of the stronger drug, earlier in the treatment journey.
Yeah. Good question. So I think most of us would prefer to have pomalidomide at least as an option for second line therapy, because most patients now, and this has changed in the last couple of years, but most patients in that setting are going to be progressing from lenalidomide, and either in the form of maintenance or upfront treatment. And when we look at what our options are, POM is likely the best choice right now for patients who are progressing on lenalidomide. Um, we would like to combine pomalidomide with daratumumab. And there's some recent research published by Dr. Bayless from Calgary that supports that. But currently there isn't funding in place there. So I think it's advantageous to have POM as an option second line. We used to have that option in Ontario until almost 2 years ago now, that they changed it so that you'd have to have failed a proteasome inhibitor. But I think it may not be the choice for every patient in second line, but it would be the choice for many patients in second line if everyone could access it.
Awesome, thank you. So now a question about CAR T cell therapy. So in the protocols for CAR T cell therapy, is there a high dose chemotherapy step, just like in stem cell transplant?
Yes, there is. So that's called conditioning. It's not the same as the necessarily the myeloablative conditioning that we use for auto stem cell transplants, which is melphalan 200 milligram per meter squared. But for example, a common one would be fludarabine and Cy, and so you would see like a flu-Cy conditioning. And that really you need to have tolerance, and also it would have the added benefit of clearing out some of the myeloma cells. But yes, there is a high dose chemotherapy component.
So is it less aggressive than the melphalan? Or
Yeah, I would say so.
Mhm. Okay, thank you. So it wouldn't be a
I will say
webinar.
though, sorry, just to interrupt again, I will say though that you may see some data coming out of parts of the world where they are doing CAR T cells in people in their 80s. I personally don't think that the type of conditioning chemotherapy that is used will be tolerable in patients who are that mature.
Okay, thank you. So it wouldn't be a webinar these days without actually talking about COVID-19, the current situation. And so basically, someone just asking, what the experience is in Canada or in your institution with multiple myeloma patients and COVID-19.
Yeah, so very topical question. So, I would say that in Canada, and I've had a lot of meetings in the last few weeks with my colleagues in Canada, and we've talked about this a lot. We've been pleasantly surprised about the lack of impact that COVID has had in terms of making our patients sick. We don't entirely understand why, because most of us were worried about having patients who tended to be on the older side, many on chemotherapy. Part of the reason we think is that myeloma patients in general are better at isolating than the average person, because most of them have done it before, and so there may be an aspect of that, better at hand washing, protecting, etc. There may be a component of the immune system that, a lot of patients who get very sick from COVID, it's because of a really strong inflammatory response. Maybe myeloma patients aren't having that. I suspect it's more the former than the latter. There in Ottawa, we have not had any COVID patients in our COVID positive patients that we know of in our practice. Most of the country is the same. There's a couple of centers that have had a couple of positive patients, but no serious cases, with the exception of Quebec, which has, I think it was termed this morning, the unfortunate distinction of being the epicenter. They've had a couple of more patients that have been more seriously affected, but overall it's been less. And most places have been able to continue chemotherapy with a few exceptions, and those exceptions have been covered by sort of alternate regimens. And so all in all, I think things have been going really quite well for most myeloma patients.
So basically, that was that you were actually just touched on the next question, which was, what has changed, when it comes to the treatment of myeloma because of the pandemic, and um, um, I guess in terms of I lost the question here. Sorry.
It's okay.
So yeah, what's changed? And so you're favoring more oral treatment regimens, or delaying treatments with chemotherapy. What are like the high level changes?
Yeah, so big picture changes that happen. So I think most transplant centers stop doing transplants for about 8 weeks, just because you can imagine that being profoundly immunosuppressed during a pandemic is less than ideal. Most centers are now open again and ramping back up stem cell transplants. Many centers delayed the starts of some IV treatments. So for example, in Relapse, if you're going to get Revlimid and Daratumumab, they were just started on Revlimid with the intent to add Daratumumab now or in the summer when things open up. And then the other would be for newly diagnosed patients. Many centers substituted Ixazomib or Ninlero, which is like a pill version of Velcade in a way, for Velcade just to reduce the trips coming in. So there's been some minor modifications like that. The biggest issue has been transplant, but that should be improving now.
Awesome. So we have just two small questions left here. Again, with the COVID-19, how does it work with referrals now? Once someone is referred, is it a telemedicine appointment that they would receive, or how is it? Are you still seeing patients in the clinic?
Yeah, good question. So it varies a little bit from center to center. We our center only sees new consults in person, especially new myeloma cases. The hospitals are quite locked down, for lack of a better word. So everybody who comes to the hospital has screening questions. All the staff have to sign into an app, etc. All the patients are quizzed before they come in, and at the door everybody is masked, the appointments are down, and so I think it's generally quite safe to come for a consultation. I think some hospitals were doing exclusively distance visits for a period of time. I think that's stopped now for new patients. For second opinion patients, again, our center would see patients in person if it was the first time. For patients on ongoing follow-up, it really depends. So most of those visits have been virtual or on the phone. But if there's something that needs to be assessed in person, then the clinics are open, and that would be for every center.
Thank you for the clarification there, for the extra info. So last question, again with CAR T cell therapy. Is there any for someone who's had a stem cell transplant, can they still potentially get CAR T cell therapy?
Good question. Yes, absolutely. So most patients now who do get CAR T cells are patients who have had transplants in the past. And so no reason why that would change in the future. I think, again, as these treatments move further up, so earlier in the stage of the disease, we may get to a place where we do CAR T cells instead of transplants. So that could be one option down the road. But as of right now, yes, if you've had a transplant, it's not a reason why you wouldn't be eligible for CAR T cells down the road. And most patients who have been studied, they have in fact had a transplant before.
Thank you. So, I mean, I think, getting a lot of really great feedback here. You did a really great job at explaining everything, and everyone really appreciates you taking the time to give this presentation. I think I speak for everyone when I say that we're really lucky to have researchers like you in Canada who can help with research, essentially. So thanks again for taking the time today out of your busy schedule to come and present to us.
You're welcome. Thank you, everybody.
Yeah. And right before we end the webinar, I just wanted to remind everyone our next webinar is on Wednesday, 2:30, and on following and understanding your serum free light chain test results, and you can find that on our website to register. Thanks again, and have yourself, Dr. McCurdy, have yourself a wonderful rest of the afternoon and evening.
You too.
Thanks. Bye-bye.
Bye.